Hello, I am Shafir Rahman, and today we are going to discuss about the nephrotic syndrome. Now, nephrotic syndrome is a very common pathology which nephrologists encounter in their outpatient department and wards, but for the defining purposes, we just say that it's a nephrotic syndrome, and the other entity similar to that is a nephritic syndrome, and we just subdivide both of them in order to understand the degree of proteinuria. But in reality, what it is, it's a spectrum of a disease. It's a spectrum related to the degree of proteinuria. And then if the proteinuria is greater than 3.5 gram per day, we say it's a nephrotic syndrome. But if it is less than 3.5 gram per day, we say it's a nephritic syndrome. On renal biopsy, what happens is that some of the times we can't differentiate both of them, and we just find the amalgamation of the patterns. Like sometimes you also have nephritic pattern. So for the purposes of understanding, what we say that nephrotic syndrome is the glomerular disease in which there is the degree of proteinuria greater than 3.5 gram per day. Now 3 plus proteinuria or 3.5 gram per day is defined as nephrotic syndrome. So it means that whenever we are seeing the urine RE report and we are seeing that 3 plus ticks on that report, so we have to just suspect that nephrotic syndrome can be happening in that patient. Now just think about this thing, that glomerulus is a structure having capillaries, having basement membrane, and when that gets leaky or when it gets diseased, so what happens that when its pores will be increased, and what will happen that it will start leaking out the proteins. Now if we can recall that proteins are the important structures in the formation of enzymes, it's important structure in making the antibodies, it's the important structure to maintain the coagulation profile. So what happens that when proteins start losing, so one of the important protein present in our body is the albumin. Now the albumin, when it will just try to leak out in the urine, what will happen that the first thing which happens is the loss of oncotic pressure in the bloodstream. So albumin is generating an oncotic pressure. So when that oncotic pressure has been reduced due to spilling of that protein in the urine, what will happen that the water will shift the space from the bloodstream towards the interstitial space or in the third spaces, and hence edema will form, which is the hallmark feature of the nephrotic syndrome. Then the second thing which I want to highlight is the hypogammaglobulinemia. So when gamma globulins are lost in the bloodstream, so I think so you're all recalling is that antibodies generation will stop producing because it is leaking out in the bloodstream, and then we have deficiency of IgG, IgM, IgD and IgA, major classes of antibodies. So what will be the outcome? The outcome will be the infections. Nephrotic syndrome patients are prone towards infection just because of this leakage. Now similarly, it's a protein antithrombin 3 which is trying to which is, you can say that it's sort of balance between coagulation and procoagulant and anticoagulant balance. So that balance is disturbed and body becomes procoagulant when antithrombin 3 is leaked out in the nephrotic syndrome. So you will find a patient with hypercoagulable state in which they are at risk of strokes, they are at risk of myocardial infarction just because of this reason. And then when the proteins are lost, so liver starts generating a greater amount of fats in the form of lipids and cholesterol, and what will happen that hyperlipidemia and hypercholesterolemia is usually found in the nephrotic syndrome. So if you can see that you can find these things on very cheap lab investigations like simple blood lipid profile, and as well as you can find it on urine RE. So you can easily find out that with proteinuria as well as hypercholesterolemia and hyperlipidemia, some of the signs of the nephrotic syndromes are quite evident on these cheaper um, you know, lab investigations. Now, nephrotic syndrome has been subdivided into different categories, and these all categories are related to one another in a way. So let us try to start from first is the minimal change disease. So minimal change disease is the most common cause of the nephrotic syndrome in children, and usually it is found in the children. And so regarding the minimal change disease, that is a nephrotic syndrome subtype most commonly found in the children. So it's usually idiopathic, means that there is the cause is not known, that how it is occurring, but its association is usually with the Hodgkin lymphoma. Now, lymphoma association is important in a sense that I will just come back in a minute towards why the association of minimal disease with Hodgkin lymphoma is important. Let us first of all understand the glomerular basement membrane, that how it is designed. Now, if you can see that endothelial layer, basically this is a layer of cells having endothelium. Lying above is the basement membrane, and then there are cells which are epithelial cells, or also known as the podocytes. So in these three layers, what happens that whenever any sort of damage to this basement membrane, podocytes or endothelial cells will occur, proteins have to start leaking out from this basement membrane. Now, what happens in the minimal change disease is the process known as effacement of the podocytes. Now, effacement of podocytes are usually due to the cytokines which has been released in the bloodstream, and usually in the Hodgkin lymphoma, the Reed-Sternberg cells release the cytokines. Now, what it will doing that it will start effacing, or you can also think that structured architecture of the podocytes will be changed, and in that changing, what will happen that the structure of glomerulus will be distorted a bit. So when you see it on H&E staining, you will see the normal glomeruli on an H&E staining in the minimal change disease. You will not find a lot of things on the renal biopsy. So you might see a lipid in the proximal tubule in the kidneys, and effacement of the food processes are found in the electron microscopy. But there are no immune complex depositions, and immunofluorescence pattern is negative. Now, why this concept is important to highlight is that in minimal change disease, for example, a patient is coming for you in the outpatient department. So what you have to do is that if you will just order the renal biopsy, so you are doing a harm to the patient instead of doing it good, because usually they are children, and you have to avoid the invasive procedures as long as you can do that. So for minimal change disease, the best course of the treatment is the trials of steroids, so that cytokines should be removed from the bloodstream by the steroids, and just wait and see that what is happening. So what it's going to do is that trial of steroid will just try to avoid the cytokines in the bloodstream, because as you all know that it will work on the genetic machinery, and it will just inhibit all the NF-κB pathway and everything, and in that way T cells can't release the cytokines. So usually in minimal change disease, there is a selective proteinuria, but means that it loses albumin, but it won't lose the bigger immunoglobulins. So it's usually the degree of proteinuria is not too like the proteins are losing, but the important proteins like immunoglobulins, which are necessary to fight infections, are not lost. So usually these patients have a good response to steroids, and renal biopsy is usually not needed in such patients. So the key points which you have to understand is that it will have normal glomes on H&E staining, so renal biopsy doesn't make it any further diagnosis. You can easily just with the lab investigations you can diagnose this thing. On electron microscopy, you will see the effacement of the food process, meaning the food process has been changing in structure and the food process of the podocytes, which are also the epithelial cells. And then there is no immune complex depositions. And why immune complex deposition is important, let us try to find out in the other subtypes. Now the second, if you can see the structure of the glomerulus, so there is a Bowman capsule, and in between the Bowman capsule there is the glomerulus, and then there is a Bowman space. In lobules, these glomerulus are divided into various lobules, and the functional unit is also containing capillary basement membrane and also mesangial cells, the pinkish structure around the capillaries, and they have also a role which we will just come in a minute, that how in which diseases mesangium try to overexpand itself. So simply the effacement of the food process is the hallmark feature of the minimal change disease. Now the second thing is the focal segmental glomerulosclerosis, which is also known as FSGS. Now focal segmental glomerulosclerosis doesn't respond well to the steroids as opposed to minimal change disease. So in that way you can easily remember these two diseases, and right now we will start discussing about what the focal segmental glomerulosclerosis is all about. It's the most common cause of the nephrotic syndrome. In the OPDs and wards and everywhere you will find it a lot. It's most commonly found in African Americans and Hispanic population. Again, it's idiopathic meaning that it is having no known or cause of origin is not known, and it's usually associated with HIV, heroin use, and sickle cell disease. And also related, one other point I would like to add is it's also associated with the obesity. So in HIV induced nephropathy, one of the things which you have to have inside the differential diagnosis list is the focal segmental glomerulosclerosis. Then the second thing is the heroin use, and usually heroin use is also associated with FSGS, so you have to keep that thing in mind as well. And then in the sickle cell disease also it is important to have this differential diagnosis inside your head. Now focal means that a part of the glomerulus is just few of the glomerulus out of the section in the renal biopsy has been shown the sclerosis. If you can see this, that many of the glomeruli in this focal segmental glomerulosclerosis are normal, but only some of the glomeruli, the segments of the glomeruli, might be showing the sclerosis or thickening. So it means that the word is highlighting its pathology pretty well, that it's focal. Focal means that some of the glomeruli out of the section are showing abnormality, and segmental means only a segment of the glomerulus is abnormal. So focal and segmental sclerosis on H&E staining on renal biopsy, then again it is having the effacement of food process just like in the minimal change disease, because definitely that was also going through the cytokines. Its process is not known, because in that disease steroids were showing action, but here the steroids are not showing promising actions. So then there is no immune complex deposition, there is negative immunofluorescence. So that's how these things are working here. So if you can see this slide, so you are seeing a segment of the glomerulus is having problem. It is having sclerosis or thickening or pinkish-like structure, but not all glomeruli are abnormal. Some of the glomeruli are absolutely normal in a section of a renal biopsy, and it will have a poor response to steroids, and ultimately it leads towards chronic renal failure. So it's a disease which is having worse prognosis or worse outcomes. Now the third subtype is important, which is known as membranous nephropathy, And again, you have to learn that it is much more important in the Caucasian adults. So FSGS was important in Hispanics and African Americans, but in the Caucasian population, you will usually see the membranous nephropathy, again idiopathic. You don't know the cause. What's the cause is all about. But usually the disease has been shown to have an association between hepatitis B and C viruses, some of the tumors, systemic lupus erythematosus, and drugs like NSAIDs and penicillamines. So these are some of the association lists which you have to understand, and most likely hepatitis B and C uh, usually have this sort of membranous nephropathy. So now, what is happening in the membranous nephropathy? You will have the thickened glomerular basement membrane. So like the three layers which what we were talking about in the start, that endothelial layer, again, on the upside of it is the basement membrane, and above of it is the podocytes or epithelial cells. So the abnormalities of nephrotic syndrome is just going between these three layers, and these three layers are the main culprit in the pathogenesis of the nephrotic syndrome. So it will have a thick glomerular basement membrane. So when it will be thick, so it will be not normal. When it's usually due to the immune complex deposition, and you will see the granular immunofluorescence on electron microscopy. So now this disease is associated with immune complexes. And what we have talked about in the start in the first two diseases, it was not associated with immune complex formation or immune complex deposition, but it is shown that membranous nephropathy is associated with immune complex deposition, and usually pattern is known as granular immunofluorescence. Now, if you just see the three layers, endothelial layer, above it is the basement membrane, and above it is the epithelial layer. So usually beneath the podocytes or the epithelial cells, you will see the deposits of immune complex deposition with a characteristic spike and dome appearance on electron microscopy. Now let us try to discuss what does the spike and dome appearance on electron microscope means in the membranous nephropathy. So just for the sake of understanding, the slide is looking that there is a thickened glomerular basement membrane. You will see a pinky structure and a little bit thickened membrane. But why the spike and dome appearance is there? So if you can see, basically see that, for example, this is the endothelial layer, and above its basement membrane, and then there is an epithelial layer which is also known as podocytes. So the immune complexes, let us suppose it's just depositing subepithelially. If you can see these spots, so what will happen that these podocytes will start secreting basement membrane, and that will cover those immune complexes in a way that it will form spikes and domes, just because it wants to be sit on the basement membrane, so it will start secreting above that immune complexes. So in that way, spike and dome appearance will occur in the membranous nephropathy. So if you can see here that it will have a thickened glomerular membrane on H&E, on renal biopsy, and it's because of immune complex deposition, and it's basically granular immunofluorescence. And then there is subepithelial deposits with spike and dome appearance on electron microscopy. Now the fourth category is membranoproliferative glomerulonephritis. Membranoproliferative glomerulonephritis. Now it will have a thick capillary membrane on H&E, often with tram track appearance. And it's also due to immune complex deposition, and also known as granular immunofluorescence. So now you have to understand what the tram track appearance means. Again, I would like to say that there is an endothelial layer above its basement membrane, and then there is a podocytes or epithelial side. So if the immune complexes are depositing on the basement membrane, so alongside of the capillary is the mesangial cell, which will start dividing those immune complexes and will form the appearance of the tram tracks. A thick capillary membrane on H&E, because capillary means the endothelial cells will have a basement membrane on the top. So when immune complexes are deposited on that membrane, what will happen that mesangial cell will start secreting so that it should divide the immune complexes into two, and hence it will thicken the basement membrane or the capillary membrane. So it usually have two types, type 1 and type 2, depending upon the deposits of the location of the deposits of immunofluorescence. So first is the subendothelial space, the subendothelial side, and the other is the intramembranous side. And if you can see that type 1 is subendothelial and it is associated with HBV and HCV, hepatitis B and C virus, just like the membranous nephropathy. And type 2 is associated with C3 nephritic factor. So we will come back towards C3 nephritic factor in a minute, that what will happen that. So type 1, which is subendothelial, it is associated with hepatitis B and C virus. Type 2 is intramembranous and it is associated with C3 nephritic factors. So if you can see that complement C3b converts into C3a and C3b with the help of C3 convertase. Now when an antibody is stabilizing C3 convertase, so what will happen that C3 will keep on converting into C3a and C3b, and that's what's happening in the membranoproliferative glomerulonephritis, in which C3 levels start decreasing. When C3 convertase is stabilized, it is not inhibited but it's stabilized and keep on converting into C3a and C3b. So this is the pathogenesis of membranoproliferative glomerulonephritis, tram track appearance due to mesangial cells secreting so that it should divide the immune complexes, and hence it is thickening the capillary membrane. So again, the second disease is the diabetes mellitus, in which there is high serum glucose, and that leads to non-enzymatic glycosylation of the vascular basement membrane. And when it will happen, so it will have the arteriosclerosis, which is known as hyaline arteriosclerosis, due to leakage of the proteins due to high serum blood glucose and non-enzymatic glycosylation of vascular basement membrane. And in diabetes mellitus, afferent arteriole is more affected than the efferent arteriole, and hence when the efferent arteriole will just contract, or you can say that it is blocked due to hyaline arteriosclerosis, it will generate a backward pressure and it will try to generate a hyperfiltration pressure in the glomerulus. So it will generate the hyperfiltration pressure in the glomerulus, and hence proteins will start leaking out, and this is the start of the pathogenesis of diabetic kidney disease, that initially there is a hyperfiltration injury and GFR is increased up to 130 and 140, and then it will start gradually decreasing and it will start manifesting later in life as a chronic kidney disease. So hyperfiltration injury leads towards microalbuminuria. Hyperinfiltration injury leads to microalbuminuria, in which protein starts to leak out, and then it later on progresses towards an end-stage renal disease from micro to macroalbuminuria, but it's very late. So eventually it progresses to nephrotic syndrome, and it is characterized by sclerosis of mesangium and formation of the Kymel-Stein-Wilson nodules. So mesangium will be sclerosed due to hyperfiltration injury in the diabetes mellitus, and this can be slowed down with the help of ACE inhibitors, and that's why ACE inhibitors are prescribed to diabetic patients. So when there is sclerosis of mesangium, so what will it form? It will form the Kymel-Stein-Wilson nodules. So diabetes mellitus is also one of the cause of the nephrotic syndrome, in which there is initially the hyperinfiltration injury due to targeting efferent arteriole and hence hyaline arteriosclerosis, and then hyperfiltration pressure, initially microalbuminuria, but later on it just progressed towards end-stage renal disease and can cause leakage of much bigger proteins, And the sclerosing of mesenchyme due to hyperinfiltration is, and there will be formation of characteristic nodules which are known as Kymel-Steen-Wilson nodules. And ACE inhibitors is used to slow down the progression of hyperinfiltration injury. And the last one is the systemic amyloidosis, and kidney is the most commonly involved organ, as well as other organs are also involved like heart, like nerves, but kidneys is the most commonly involved organ. And what's the presentation of the amyloidosis? It's the nephrotic syndrome. So amyloid deposits in the mesengium, and that will lead towards nephrotic syndrome, and it is characterized by apple green birefringence under polarized light. So if we summarize the nephrotic syndrome, that what is nephrotic syndrome? It is the degree of proteinuria which determine that whether it is nephrotic or nephritic syndrome, started from the membranous uh, minimal change disease, and then focal segmental glomerulosclerosis, in which minimal change disease can be treated with the steroids, and focal segmental glomerulosclerosis can be treated with steroids. Then there is membranous nephropathy, in which there is thickened basement membrane, and then there is type 1 membranoproliferative glomerulonephritis, and then there is type 2 membranoproliferative glomerulonephritis, and each subcategory is um, uh, important in the nephrotic syndrome. And then we have the diabetic kidney disease, in which we have characteristic Kymel-Steen-Wilson nodules due to mesangial expansion, and then there is the systematic amyloidosis, which presents as nephrotic syndrome.